This film is intended for eye surgeons for training and education purposes. Viewer discretion is strongly recommended.
Hi, I'm Dr. Deepak Megur, and he is a 60-year-old man. He presented to the hospital with a history of severe pain and redness, vomiting, and blurred vision for the last 5 days. And in fact, he was very toxic. So in examination, he had corneal edema. The antechamber was extremely shallow. The pressure weighs around 50. So typically it looked like an angle closure glaucoma. The details were not very well clearly seen because of the patient was extremely uncomfortable at the slit lamp, and also there was significant corneal edema. So after medical treatment for the control of inflammation and the raised pressure, the cornea did clear up, and what we can see is the clinical picture here. The antechamber is extremely shallow. It doesn't have the classical iris Bombay picture, but appears that the entire lens iris diaphragm is pushed forward. There is pseudoexfoliation. There is a cataract, but it is not the intumescent variant which we see. It looks more like a nuclear cataract. But on the face of it, it appears that the lens iris diaphragm has been pushed forward, and that itself is causing the blockage of the angle. And we might be dealing with a very thick lens. So when we did the biometry, these are the findings. The antechamber is extremely shallow, just 1+ in the central quadrant, which is the deepest. And as we go to the mid-periphery, we see that the iridocorneal contact is there. And the lens thickness, as we can see, is significantly thicker. So we're dealing with an extremely thick lens and a very shallow antechamber. When we do an anterior segment OCT, it gives us an overall view of the morphology. And what is striking is the bulky lens is pushing the lens iris diaphragm so much forward, and we're having an angle closure. Please note that it does not look like the typical iris Bombay feature which we have in an relative pupillary block mechanism. So this is definitely a phacomorphic type of an angle closure glaucoma, and in this situation, I think extracting the lens is going to be therapeutic. But the challenge is the surgery is going to be very tough. We have to deal with multiple challenges. Number one, the visibility will not be great. The cornea has taken a hit. We've got pigments on the back of the cornea. The antechamber is very shallow. There's no space for us to maneuver. Pupil is mid-dilated. It's not dilating very well. And most importantly, there is evidence of zonular instability. And it may be challenging to deal with the capsular bag itself because there is every chance that we may end up losing the bag. So with these challenges in point, we have to plan the surgery for this patient. To safeguard the endothelium, it's always wise to use a dispersive OVD and a cohesive OVD whenever required because we don't have space to maneuver, and our goal should be to minimize any trauma to the endothelium. To deal with the pupil, we may consider using a pupil expansion device or hooks if necessary. But the real challenging aspect would be to deal with the loose bag. So to counter the zonular weakness, my plan is to first use a CTR and then try to perform the surgery. If it doesn't work well, then I would be using the capsular hooks. So that is my plan which I have written down here. The compromised zonules, they pose a significant challenge while managing the nucleus. So we may have an inadvertent capsulozonular complication like a extensive zonular dehiscence or a posterior capsular tear, and also there is a probability that we may have a nucleus drop in this case. With these possibilities in mind, let's begin the surgery. So the incision which I am planning is superiotemporal. I am planning a scleral tunnel incision simply because in the worst case scenario, if I have to sacrifice the bag, my go-to lens is always going to be the iris clip lens, and it is a PMMA lens, so it's easier for me to extend the scleral tunnel incision to insert that. Or in the worst case scenario, if I'm dealing with a complicated situation where I'm forced to extract the nucleus manually, then again I'm going to use this incision. A small 2.5mm scleral tunnel is created. I've chosen superiotemporal simply because in the worst case scenario, if the patient requires a filtering surgery, later on I want to keep the superior-nasal quadrant virgin. The side ports are made. I'm using a combination of sodium hyaluronate and chondroitin sulfate. That's a dispersive OVD to coat the endothelium and also to pressurize the eye. I expect the zonules to be weak, so instead of puncturing the forceps, I am puncturing the anterior capsule with the 26 number needle itself, so that will get me a nice cut and the flap is raised. Performing the rhexis was not difficult, and I was glad that I could get an appropriately sized rexes. The most important step here would be to get the hydrodissection right, because in a loose bag, when we want to maneuver the nucleus, it has to be totally free from its attachment to the capsular bag. So hydrodissection becomes extremely critical, and as I do the hydrodissection, the nucleus pops up a little bit. So I just go and decompress it, and I'm trying to mobilize the nucleus, but it doesn't move. As I'm trying to negotiate the nucleus, you can see the bag also moving along with the nucleus, suggesting that the zonules are not in great shape. So when you're trying to rotate the nucleus here, always mandatory that we dip down on the nucleus and then rotate the tangential. But still, I'm not so happy with the overall zonular health status. So now is the plan to put in a CTR. That is my first option here. Simply because if I have to use a capsular hook, it's going to be much more easier for me to perform the phacoemulsification. The only thing is I need to make 4 more additional ports, and it requires a little bit extra time. So if I can manage with CTR, it will be fine. That's what I'm trying to do now. The superficial epinucleus and cortex is aspirated. Space is created under the capsule by using OVD. Then the CTR of regular size, that is 11 and 13 mm, that is being threaded into the capsular bag. Typically, again, I'm supporting the ring with my left hand so that the stress on the bag is minimized. Gently, the CTR is threaded into the capsular bag. So far, so good. But at this point, I'm still not convinced that CTR is going to do the job for me. Now what I do is I go back and repeat hydrodissection again with the CTR inside. And now I'm trying to see whether this repeat hydrodissection is going to loosen the nucleus from its bag attachments. I've repeated a couple of times and let me see. Okay, this looks better. The nucleus is slightly more mobile. The bag is not showing any movement. So I thought I'll start my phacoemulsification. The idea is to create a trench and then do a chop maneuver. The trench is created. I'm performing a vertical chop. So when you're trying to divide the nucleus in the bag, which is extremely loose, we need to be as gentle as possible. I'm just lifting the nucleus with my right hand, and the chopper goes down vertically, and then there's a lateral separation. Second chop is being done now. But at every moment I can see that the bag is moving around. It's trying to come anteriorly. At the same time, the pupil is also going down a little bit. I'm trying to place the chopper at a deeper plane and try to get this crack out. But because there is no counter traction by the zonules, I find it difficult to do lateral separation and also to rotate the nucleus. So anyway, I persist with doing the chop maneuvers. And one small fragment comes out of the bag and it's emulsified. Now you have got a bag which is slightly empty because of that one small piece which is gone. As I try to rotate the nucleus, it doesn't rotate very easily. And as I'm trying to pull this piece out of the bag, I find it very, very difficult to pull it out. The moment I try to pull it out, it seems that the bag also is coming along with it. With the great difficulty, I could manage to get one small fragment again out of the bag. But at this stage, I thought this is enough. I cannot risk anything more. So at this stage, I thought we have to support the capsular bag. So time to use the capsular hooks. So I make 4 incisions which are posterior limbal with very small corneal tunnel, more like a stab incisions. And these are the 4 areas through which I'm going to anchor the capsular bag by using these capsular hooks. So the capsule hook is gently introduced into the antechamber, then goes under the capsular rexus margin. Important point to note here is I'm not going to pull it too much. It's just enough to hold it. Excessive pressure can tear the rexus margin. The plan is to use 2 hooks first in the opposite quadrants, and the next pair is going to be in the second opposite meridian. Again, I'm not going to stretch them too much, just enough to support it. So now with the 4 hooks in place, let's see how the bag behaves. So these 4 hooks are anchoring the capsular bag. The hooks are stretched just a bit now to get a reasonable visibility. Along with the capsular bag, it also prevents the pupil from coming down. So that's the advantage of using a capsular hook. It also acts like an iris hook inadvertently. Now because the bag is held by these hooks, the nuclear fragment which you're refusing to come out of the bag now can be pulled out of the bag with greater ease. The nucleus is about grade 3 plus, and it does require some amount of chopping and lateral separation to divide it. It's not extremely soft, but nevertheless, with the bag well supported, it's easy. The chamber is replenished with OVD, the remaining heminucleus is brought into the line of action. Tip is buried into the nucleus and the chopper goes down vertically first, and then there is a lateral separation maneuver. Now, because there is a lack of space, I want to be as slow as possible. I don't want to be near the cornea. So as you can see, the emulsification is being done in a very controlled manner, and the plane is probably at the level of the pupillary margin. And after every fragment is out, I go in and put in OVD to safeguard the endothelium, and the final piece is now emulsified. So with the nucleus out now, we need to deal with the remaining cortex. Thankfully, the cortex is not much, but still it needs to be removed very gently, because majority of times the dehiscence can worsen during the cortex aspiration itself. But the CTR is providing a equatorial support, so that is one good thing which is going to help me when I'm trying to remove the cortex. But as always, I need to be extremely careful not to use excessive force. In such eyes with pseudoexfoliation and compromised zonules, there is always a risk of fluid misdirection, and fluid misdirection can push the fluid in the burger space that can tent up the posterior capsule, and that is a high risk situation to induce a posterior capsular tear. So we need to be mindful of that as well. So try to work as anterior as possible and be careful to observe that the PC is not within the vicinity of your action. So once the cortex is out, now is the time to disengage the hooks, simply because my strategy is to put the lens in the sulcus. So with the hooks on, I can't do it. The strategy which I'm going to use is the IOL trap technique. The space is created under the iris and above the capsule for placing the multi-piece lens in the sulcus. The distal haptic is gently guided under the iris and above the capsule, while the trailing haptic is again dialed into the sulcus. The technique which I'm using is the IOL trap technique. This is what I call, and this is my preferred technique for fixing the lenses in eyes with generalized zonular weakness like this. The haptics will be in the sulcus and the optic is pushed back in the capsular bag. So before doing that, I need to remove all the OVD which is behind the lens in the capsular bag. The irrigation cannula goes in and irrigates out all the OVD which is behind. Then the OVD which is in front of the lens is taken care of. So before doing an optic capture, I'm just going to hydrate all the ports here, and also I'm doing a peripheral iridectomy using the cutter. I've chosen the opposite quadrant simply because the subincisional area was having wound hydration and is not visible well. So now is the time to perform optic capture. With the irrigation in my left hand, the optic is pushed down so that it gets entrapped within the bag. The haptics are in the sulcus. The ovalization of the rexus is appreciated. I just pause for a moment and note that it is done well. So I believe this IOL trap technique ensures a better long-term stability of the bag in eyes with pseudoexfoliation and generalized zonular weakness. The CTR in the bag provides us 360 degrees equatorial support, and the haptics are in the sulcus and the optic is just pushed back. This balances the lens, and hopefully it's going to be stable for quite some time. The side ports are hydrated. Triamcinolone acetate is used to check for any prolapse of vitreous. There is none. So that was it. The case is done. So these are the first day post-op pictures, and the patient is doing fine. The pressures have come down to 12. The chamber is deep. The cornea is clear. The lens is well centered and stable. And this is the OCT picture which shows extremely deep chamber. The angle has widened significantly. Well, this case exemplifies that in a certain section of the angle closure glaucoma disease, lens extraction does have a therapeutic role. In this case, the zonular laxity itself was pushing the lens iris diaphragm forward. When the thick lens was extracted out and replaced with a thin artificial lens, you can see the impact which it has on the dimensions of the antechamber and the angle. So to summarize, most challenging aspect in this case was emulsifying the nucleus with a very loose bag. The bag was wobbly because of a generalized zonular weakness. So one of the most commonly asked questions is, what is the priority of your approach when dealing with such a situation? Now, in my case, I prefer to use a CTR first. That's early insertion of CTR. and then if it doesn't work, then I'm going to use the capsular hooks itself. So we can use the capsular hooks from beginning itself. That's also an option. But in many cases, I found that I could manage with just the CTR inside itself. Only thing is the CTR has to go in early. But in this situation, the zonula weakness was so enormous that I needed to use the hooks along with the CTR. There's a common fear that why to use CTR now, because in the event of a posterior capsular tear, we'll be in a tough situation. Well, the PC tear, although there is a risk, it's unlikely if you are very careful. In the worst case scenario, if the PC tear does happen and the CTR is there in the sulcus, it will remain in the sulcus most often and not. Very rarely it can drop down, but it's unlikely. So anyway, we are going to still put the lens in the sulcus with optic capture. That should be fine. But in my experience of many cases of using this technique, I haven't faced or encountered posterior capsular tear after putting a CTR when dealing with such situations. So maybe I was lucky up till now, but that's the philosophy which I follow. But it has served me well until now. So that was it. Thank you for watching and hope you found this helpful.